I'm well audible.
Yes.
Okay. So I'm honored to present an academic round on behalf of our ICH team. I was asked to present a topic of chronic liver disease. So I thought of making it slightly different. So I will discuss the approach to chronic liver disease in a nutshell, and also my discussion will be a case-based approach, which will touch almost all age-wise chronic liver diseases. But mainly, my discussion or my presentation will be on focused on age-based manifestation of chronic liver disease of the case scenario which I will be presenting. So it will be mainly on autoimmune hepatitis and Wilson's. So the objectives of today's discussion is approach to chronic liver disease in children, the clinical spectrum, diagnosis and management of Wilson's disease related to case scenario. That is the case scenario which I will be presenting, and also the diagnostic dilemma which we may face sometimes. So coming to a case profile first. So this was a patient named SK. He was an 8 years old boy, resident of Jharkhand, who was admitted from 28th of October to 31st of October in a private hospital, which I am associated with. And the child came with a chief complaint of fever, which was 4 weeks back, but is passive at the time of presentation when he came to us. He was having a jaundice for 3 weeks, and he had a similar episode of jaundice 6 months back. The history or the etiology of that jaundice was not very clear to us, but it underwent resolution, and he again started this episode of jaundice, which was lasting for 3 weeks, and he had abdominal distension, which is very well evident in the photograph, and which was also for 3 weeks, almost after the onset of jaundice. So coming to the dateline of the case, so there was a fever which was documented up to 102 degree Fahrenheit, no history of chills or rigors, and intermittent. The fever was intermittent and it relieved with paracetamol. Following the fever became passive, and then the child started having jaundice, which was almost 2 weeks after the onset of fever. He had abdominal distension, which was gradually progressive with flank fullness, which was associated with dull, aching right hypochondriac pain, as provided in the history. And on the negative history, there was no history of vomiting or constipation, no history of hematemesis melena, bleeding from any other side, no pruritus or cola-colored urine was present. There was no history of seizure, encephalopathy, disturbances in handwriting, neither behavioral changes or abnormal movements were present, and there was no history of any drug intake or previous blood transfusion. So there was a outside hospital stay for almost a week before he was sent home. And in the treatment history, there was an ascitic tap which was done, and subsequently the child was started on diuretics in the previous stay, and some relevant workup was also sent. And since there was no resolution of the jaundice and no resolution of the abdominal distension completely, so he came to us. So coming to other relevant history, in the past history, there was no other hospitalization. There was no history of any prolonged jaundice in the past. Developmentally, he was appropriate for age. He was in class 3, and he was average in studies. The immunization history was complete as per national immunization schedule. However, no supplemental vaccine was given to the child. In the family, the parents had a non-consanguineous marriage. However, there was an interesting part that the eldest sibling also died of a similar illness involving the liver with a history of jaundice and ascites. He was the fifth in the birth order. This was the elder sibling who died at the age of 10 years, and other siblings were well. So on general examination, he had pallor, he had icterus. There was no cyanosis, clubbing, or lymphadenopathy, or any pedal edema. Anthropometry wise, he was stunted, -2 Z score. Weight was otherwise appropriate, though there was ascites, which was adding to weight. Then the head circumference was normal. There was a cave ring present, and there was No sunflower cataract, however, on slit lamp. No dysmorphism, no spider nevi, no palmar erythema, and there was no features of rickets. So this is a representative photo of the of cave ring. This is not the photo of the patient though. So on per abdomen examination, his liver, there was a right lobe which was 2 centimeter below the right costal margin with a left lobe of 3 centimeter under the Ziffy sternum. Clinically, the liver span was 12 centimeter, which was certainly hepatomegaly considering his age-wise liver span. So firm, smooth surface. The liver was firm in consistency, smooth surface, irregular border. The notch was palpable and there was no bruit. The spleen was also palpable, which was 4 centimeter on the left costal margin, which a notch palpable, and there was moderate ascites clinically. So on systemic examination, otherwise was normal. The both all the other systems, as respiratory, CVS, and CNS wise, he was absolutely okay. So coming to the database, this was an 8-year-old girl, developmentally sorry, a boy. This is I'm really sorry. This was an 8-year-old boy, developmentally normal for age, gradually progressive abdominal distension. The fluid distension required tapping. That is, it was definitely fluid because the history of ascitic tap was there, preceded by a prodromal illness, that is fever. So he came with jaundice, with here a form hepatomegaly, a splenomegaly. Probable cave ring, I would say, because the cave ring examination was done outside. So we also confirmed it by a slit lamp, but it was very, very faint. And family history of sibling death, the age at the age of 10 years, due to a query liver disease. So coming to the case analysis, this is a chronic liver disease, which is the chronic liver disease because there was a farm liver, there was feature of portal hypertension. However, against this diagnosis was a duration. The duration was very short because there was only 1 month duration of jaundice. However, this could be an unknown chronic liver disease, and in the definition of chronic liver disease, the duration is actually explained on basis on the scenario of hepatitis B, where 6 months of 6 months of hepatitis B positivity is required to describe chronic hepatitis B. Otherwise, for a definition of chronic liver disease, any liver disease which presents at that point with features of chronic liver disease can be considered as a chronic liver disease without considering duration. So there was feature of portal hypertension in form of ascites and splenomegaly. So this was a decompensated liver disease, decompensated chronic liver disease because there was ascites. However, the other features of decompensation like hepatic encephalopathy or any GI bleed was not present at the presentation, but definitely there was ascites. So localization of this chronic disease was hepatic, so hepatic origin, and cirrhosis was the working diagnosis because the liver already had decompensated, which is considered as irreversible chronic liver disease. However, cirrhosis, the term cirrhosis is used for a histopathological term, but for working diagnosis, we can use the term chronic liver disease with decompensation. So now the point of our interest will be etiology. So what can be etiology of this child presenting with these features of chronic liver disease? So coming to a very popular slide, which is almost presented in all pediatric GI conferences or pediatric conferences. So the age-wise distribution of chronic liver disease, various CLDs. So as we can see in infancy, chronic liver disease, the etiology of chronic liver disease can be metabolic liver diseases like galactosemia, tyrosinemia, hereditary fructose intolerance and biliary atresia also, which slightly comes late. I mean, the features of chronic liver disease of biliary atresia comes around 5 to 6 months or after 4 months. And then there can be progressive familial intrahepatic cholestasis 1 and 2 variety, which can also goes into chronic liver disease at an infancy, at an infant age. So 1 to 5 years, that is the preschool age. Again, the metabolic causes tops the list. That can be tyrosinemia, hereditary fructose intolerance, glycogen storage diseases, which are also manifested as chronic liver disease. Then autoimmune hepatitis, slightly lower. Then hepatic venous outflow tract obstruction, again the PFIC, and Indian childhood cirrhosis, which we rarely see nowadays. So coming to 5 to 10 years age group, the list is actually headed by Wilson's, autoimmune hepatitis, and chronic hepatitis B. And then again, hepatic venous of outflow tract obstruction slightly lower down, and PFIC 3. So PFIC 3 manifestation comes a little late age, at a late age, not in the early infancy. And then 10 to 18, that in pre-adolescence or adolescent age, again Wilson's, autoimmune, chronic hepatitis B or C, NAFLD, which takes actually 20 years to develop into chronic liver disease. It can present as NAFLD, but it goes into NASH or chronic liver disease at a later age. Celiac hepatitis, drug-induced liver injuries due to use of conventional medicines and Ayurvedic preparations, mixed preparations. Then PSC, which is a very complicated disease. Someday I may discuss a case related to PSC also, and PFIC3. So our age group of interest is 5 to 10 years because our child in the case scenario is 8 years. So coming to the baseline investigations of this child, we can see the bilirubin was 3.6 with a conjugated fraction of 2.9. So hepatocellular jaundice, AST, ALT, and ALP all were raised. The INR was 1.4 in the borderline range of coagulopathy, and the total protein was 6.9 with an albumin of 2.4. Again, this is also a feature of chronic liver disease with a lower albumin due to the synthetic dysfunction of the liver. And the CBC or the hemogram was more or less in the acceptable range with a hemoglobin in the lower side. The total counts and other platelets were normal. Platelets were slightly in the lower range. Again, this is also a feature of chronic liver disease, which has which has progressed into irreversible stage. So thrombocytopenia and anemia was also present. Now coming to special investigations, the ascitic fluid tapping, which was done, there was 190 cells. So there was no spontaneous peritonitis, spontaneous SBP or spontaneous bacterial peritonitis. The protein and sugar, we can see 1.9, 103, and most important, the SAG was 2.1. So SAG more than 1.1, which actually implies portal hypertension. So the ascites was due to portal hypertensive causes. And since there was no SBP, the child was also started on diuretics. So if SBP is there, he should have been started with antibiotic first, followed by diuretics. So ultrasound of the abdomen was showing features of chronic liver disease in form of heterogeneous ecotexture. The liver span was 14 centimeter in ultrasound. The spleen was also enlarged. There was ascites still at the point when we did the ultrasound at the time of presentation. So our ascites has not resolved completely in spite of starting diuretics. The portal vein was 7 millimeter, showed hepatoportal Phe, and the mean flow velocity was 10 to 12 centimeter per second. So now coming to the etiological workup, the Wilson's workup, which we did, serum ceruloplasmin was less than 3. The 24-hour urine copper was 760. The IgG profile, that is the immunoglobulin, which we did, was on the higher range. I will explain why we do IgG also in these cases. The autoimmune workup was also sent simultaneously because when a patient is admitted with chronic liver disease, we usually send the age-wise age-wise etiological workup simultaneously. We do not wait that we should rule out one and then we go for. So these two possibilities are very close by, runs very close to closely neck to neck. So we send simultaneously this workup. And so autoimmune workup, SLA was positive, IgG was more than 1.1 times. His viral markers were negative. So someone may ask why we sent hepatitis A and E also, which are actually features of acute hepatitis, because sometimes there can be an insult, acute insult, which may actually bring out the manifestation of chronic liver diseases. So acute on chronic liver disease. So we wanted to see B, C as feature of chronic hepatitis, but at the same time we sent A and E also because he had the episode of jaundice also 6 months back. So coming to the workup for progression of liver disease. So we did an endoscopy, which was showing prominent veins. So this is the first step that he was the varices are developing. So there was a few columns of prominent veins in the lower esophagus, and a fibroscan actually, which was done, a fibroscan which was done outside. So we usually do not routinely do fibroscan in children as a marker for progression of fibrosis or chronic liver disease, because a liver biopsy is a more accurate diagnostic modality. But sometimes outside fibroscan is still done, and in adult NAFLD or NASH progression is estimated by fibroscan. So his fibroscan was showing a liver stiffness measurement which was higher than the normal range. So this also indicated that the liver has progressed to a fibrosis stage, or was a progressive liver disease which is progressing to cirrhosis or irreversible stage. So coming to diagnostic algorithm, so it was a unexplained liver disease. Any unexplained liver disease, if the serum ceruloplasmin, slit lamp, and 24 hours urine copper is done. So if all of the three are suggestive, that is a KF ring is present, the ceruloplasmin level is less than 20, and the 24 hours urine copper is more than 40, we can establish a diagnosis of Wilson's disease. This is the diagnosis and treatment of Wilson's disease by ASLD Practice Guideline 2018. So if two parameters are present, that is KF ring is present and 24 hours urine copper is greater than 40, we need a liver biopsy. Similarly, if one parameter is strongly suggestive, that is ceruloplasmin is the lower range with a clinical scenario of chronic liver disease, again we need a liver biopsy for histology and copper quantification. So again, KF ring is absent. However, the ceruloplasmin is present and 24-hour urine copper is more than 40. We once again need a liver biopsy and liver biopsy for histology and copper quantification. Now the point is that for in liver biopsy, histopathology wise, am I audible? Am I audible?
Yes, absolutely.
Okay, ঠিক আছে. So so in that case, we do a liver biopsy because there are not much specific histopathological change. However, electron microscopy in Wilson's disease actually helps because there are some specific mitochondrial changes like swelling of mitochondria, tennis racket structures, etc., which actually gives us the change of Wilson's disease, which are not very specific. They can happen in any other metabolic diseases like mitochondrial liver hepatopathy or other metabolic liver disease. However, the copper quantification is actually needed. That is the purpose of doing a liver biopsy. So copper quantification can be done if we send a liver biopsy sample in a plain vial or a sample in liquid paraffin. So biochemistry department of our institute, PGI Chandigarh, used to do that regularly. So if it is greater than 250 microgram per gram of dry weight of liver tissue, then Wilson's disease is established. If it is between 50 to 250, then again we need a molecular diagnosis. So if the molecular diagnosis is suggest, then we can establish a Wilson's diagnosis. So by molecular diagnosis, we actually mean the mutations in the specific gene, that is ATP7B gene. So till 2010, I think 200 mutations were known, but now at least 500 to 600 mutation can be possible. However, that can be done and it is much within the range now. It is not so costly now, mutation studies and genetic analysis. So if the parents want a diagnosis very aggressively in these doubtful cases, and we want to start chelation also, then we can go for molecular diagnosis also in these these diagnostic dilemma cases. So if it is less than 50, then it is almost confirmed not Wilson's. No further cards will be played for diagnosis of Wilson's. So there are other parameters also for diagnosis of Wilson's. So that is one of that is Leipzig score. So Leipzig score uses many parameters, which is like the KF ring, the neurological symptoms, serum ceruloplasmin, Coombs negative hemolytic anemia, liver copper. So they are as per this score, we need a liver biopsy in all cases for copper estimation, then urinary copper and mutation analysis. So we can progress stepwise also. Suppose we have these four, we can do first these four. So if we can give a score more than 4 by performing only these four parameters, then again we can establish a diagnosis of Wilson. But if it's not there, then we can go for the next step. So as per Leipzig score, the score more than 4 diagnosis established, then 3 diagnosis possible, more tests needed, and 2 or less, that is diagnosis is very unlikely. So now we can interpret the diagnostic test of Wilson's also, like serum ceruloplasmin less than 20, false positive. That is, can be false positive in some cases like malabsorption, aceruloplasminemia, which is a condition, and then Menkes disease. Menkes disease has actually false positive, ceruloplasmin positive. Then false negative can be in acute inflammation and hyperestrogenemia. So low positive predictive value of ceruloplasmin. Only ceruloplasmin lower range has a low positive predictive value. Serum copper, which is not very popular test in our country, But however, some research labs or some teaching institution, they actually regularly do that. So serum copper is the non-ceruloplasmin bound free copper, which is the free copper. So it is very difficult to estimate the free copper directly. So what we can do is, if we get the serum copper, total copper, and then if we subtract the ceruloplasmin bind copper by 3 into ceruloplasmin level, then we can get the free copper, which is the method of estimation of free copper in an indirect way. So free copper estimation is sometimes needed when we are actually following the patient, and when we decide to withdraw therapy, chelation therapy. So at that time free copper is needed. I will explain that in later part of my discussion. Then the 24 hours urine copper, which is greater than 40, so it can be high, that is false positive in hepatocellular necrosis or cholestasis, and even in contamination. So they can be falsely high, and even false negative where there is incorrect collection. So we have not collected the whole 24 hours urine volume, or even a child without a liver disease can sometimes have a false negative 24 hours urine copper. So then the DPLSMN challenge, which can be done, which is though not routinely followed in adult guidelines, however in pediatric guidelines of Wilson's disease, still DPLSMN challenge is explained in some guidelines or some good hospitals. They are routinely doing that the greater than 1600, then we can go for a diagnosis of Wilson's disease, following if the other parameters are also positive. Then the hepatic copper estimation, which I've already explained. So cholestatic syndrome can have falsely positive estimated high copper, and 50% of the hepatic Wilsons can have false negative copper. That is because the copper deposit is actually patchy. So when we take a percutaneous liver biopsy, that area may not have a high copper. So in that way the copper estimation can give us a false negative result. So coming to the case now, so the unit's final diagnosis of our case was a decompensated cirrhosis with portal hypertension, and the etiology considered was Wilson's disease. Now coming to a few slides just about Wilson's disease. So it was an autosomal disease. It is an autosomal recessive disease with incidence of 1 is to 30,000 to 1 is to 50,000 in some countries. The age group can be 5 to 70 years. So wide at a wide age range, Wilson's disease can present. Wilson's disease can present with a manifestation of only hepatic Wilson's, neurohepatic Wilson's, and only neurogenic Wilson's. So that is also important. Some patients may not have liver disease at all. They may present with neurogenic manifestation only, and they are usually dealt by the neurologist. However, any child coming to you, coming to us in our OPD with a recent change of behavior, deterioration of academic performances, handwriting changes, we should do a ceruloplasmin assay at least and a KF ring to rule out Wilson's. So mutation of the ATP7B gene on the chromosome 13, which is the offending gene for the disease, and gene frequency 1 in 90. So coming to the pathogenesis, this is very important, as by this time we all know that ceruloplasmin levels are low in Wilson's. So it is not that the ceruloplasmin synthesis is hampered in Wilson's. What happens is ceruloplasmin is destroyed more early in Wilson's. What happens that when the ATP7B gene is not present, the ATP7B gene is defective, the copper cannot bind to ATP7B. So when the copper binds to ATP7B in a normal individual, it actually produces the ATP or the energy to for the movement of the copper to the Golgi apparatus or the endoplasmic reticulum of the cell, and which then forms the binding with the copper, with the ceruloplasmin to form the hollow ceruloplasmin. So the hollow ceruloplasmin is more stable in the blood. But when there is no ATP7B, there is no binding of copper to the ceruloplasmin. So the ceruloplasmin, which is apoceruloplasmin, is easily destroyed or easily metabolized, and so that's why the ceruloplasmin level in the blood of Wilson's patients are low. And that way the copper transport is also hampered because there is no ATP7B, so there is no energy produced to transport the copper to the lysosomes. So in simple ways, increase in copper in the liver, mitochondrial damage, oxidative injury within the cells, The copper which is excess is spilled into the brain, the cornea, and the RBCs. So that's why we also get a hemolytic anemia, DCT negative hemolytic anemia also in Wilson's. So our child also had a anemia. So clinical spectrum almost like diabetes, it can affect every organ, like the starting from the liver, the kidney, the cardiac manifestation. It can affect the eye with a cave ring, the central nervous system, which is very devastating, like deterioration in school performance. I mean, at the onset there is deterioration of the school performance, behavioral changes, incoordination, resting and intention tremors, dystonia, dysarthria, excessive salivation, mask like phases, and it can be mortal also. So if we see the clinical spectrum of Wilson's, so they start manifesting from the age of 3 years. Below 3 years, it is still unknown. We have a patient in our follow-up. We was diagnosed at 4 years. So he's now 5.5 years. So he has been started on chelation and is doing fine. So so from 4 years of age we can start suspecting Wilson's. So if we see that the hepatic Wilson's is more common, but as the age advances, neuro Wilson's is more common. I mean, more common manifestation of Wilson's disease. So this is a paper from my previous institute, PGI Chandigarh, on spectrum of pediatric Wilson's disease from PGI Chandigarh, and including other institutes which were in that locality in Chandigarh. So cirrhosis, at presentation, cirrhosis was in 46% of the patient. That is, half of the patient presented with cirrhosis at the time of presentation. Acute hepatitis can be in 16%. Asymptomatic presentation can be 13, incidentally detected with Wilson's. ACLF, that is acute and chronic liver failure, these patients actually presents with more advanced liver disease, with jaundice, ascites, and coagulopathy, developing within 4 weeks of developing jaundice. Our child was not in ACLF because there was no coagulopathy, though there was borderline INR raised. But since it was less than 1.5, I did not consider it as ACLF. However, otherwise he was fulfilling other two criteria, that is jaundice more than 5, and ascites was also present, which started within 4 weeks of jaundice. Then chronic liver disease, just only chronic liver disease without liver failure can be in 6%, and acute liver failure, that is fulminant hepatic Wilson's, which we call, can be present in 2% of cases, which is very difficult unless we can arrange for a we can arrange for a liver transplantation very shortly. So sibling skin, first degree relatives of any patient newly diagnosed with Wilson's must be screened for Wilson's. So molecular testing for ATP7B or haplotype study should be obtained and may be used as a primary screening. Otherwise, if this is not affordable, at least we should do an LFT, a cave ring, and a ceruloplasmin level for all siblings. This is what we used to follow in as a protocol, that at least get a LFT, ceruloplasmin, and cave ring for all the siblings of diagnosed Wilson case. So coming to treatment options, reduced copper intake. So low copper, so this is the first step, that we should reduce the copper intake. We should reduce the substrate. So low copper diet, nuts, chocolate, seafoods, organ meat, and copper vessels. These are the rich sources of copper. So these should be restricted. Then the next line of treatment is copper chelators, that is increased copper excretion. So we have to target increased copper excretion. For that we need chelation therapy. The only disadvantage of using chelation therapy is that we have two chelators, D-penicillamine and triantine. Both are available in the market. Triantine was very costly previously, and it was available only in the gray market. But however, for last 5 years, it has become cheaper and more available. However, D-pen is the most cheap option for chelation therapy. The only disadvantage is the D-pen can have up to 50% neurological worsening, which is explained in textbooks. However, we do not see as such right and out, but however some textbooks say that D-pen can have at least 30 to 50% of if we use 100 D-pen on 100 patients, at least 30 to 50% can have neurological worsening. So we have to be very reserved when we are using neurohepatic Wilson's or neuro Wilson's when we are using D-pen. However, we can go slowly. I mean, we can start at 5 mg per kg and then gradually rise to the therapeutic dose. Pancytopenia is another side effect, and skin rashes can also occur with D-pen. Triantine, which also has neurological side effects, but however the incidence is very less. I mean, compared to D-pen, that is 10 to 25%. Some textbooks have mentioned, some literature has mentioned that even 25% cases of neurological worsening in triantine. However, in my experience, and in our experience, none of the cases where we have used triantine did had any neurological worsening. It can cause gastritis and pancytopenia also. While using D-pen, there should be a gap between D-pen and zinc, that I will explain later. So coming to reduced copper excretion. So the guideline, what the guideline says, that use either D-pen or zinc, but practice in most of the national institutes or most of the practical protocols say that we can use both at the same time, that is starting both chelation and reduce copper excretion by zinc. How zinc acts? Zinc actually binds to the metallothionein, and when this binds with the copper cannot be released into the copper. Actually, the absorption of copper is actually slowed down. So when the enterocytes are shaded due to normal aging, so along with it, copper is also shaded into the stool. So in this way, zinc actually acts as a reduced copper absorption. However, zinc cannot act as a chelator. So when there is already advanced liver disease or advanced neurological damage, we have to start a chelator also. There are other options which are also available now. Only advantage of this ammonium thiomolybdate, it is also a chelator. It has also neurological worsening side effect, but very less, that is 5 to 10%. So practically almost negligible way, but however it is not widely available in India, and it is still in experimental stage in some centers. Vitamin E can also be used just to prevent oxidation injury. So the last option, where a patient is presenting with a cirrhosis, advanced stage liver disease, or a fulminant hepatic Wilson's, fulminant liver failure, their liver transplantation is the only treatment which we can offer, and also gene therapy for the siblings or other members of the family. So for that we use the Nezer index, which is actually used for fulminant hepatitis. So a higher Nezer index, we have to go for liver transplantation as the only rescue. So monitoring of treatment, which I was saying earlier, that monitoring interval, that is weekly till resolution, then 1 to 3 months for 1 year, and then 6 months. So what we monitor first is the clinical improvement. If the patient had features of jaundice, hepatic manifestation, or neurological worsening, there should be a clinical improvement. Once we start chelation, clinical improvement will be there. However, we have to be guarded about the neurological side effects also, extrapyramidal side effects and neurological worsening. So disappearance of KF ring can occur after 1 year of chelation. LFT should be monitored. So LFT will improve in a hepatic Wilson's, just like our child has transaminasemia and jaundice. Free copper, that is which I was saying, if should explain, we should estimate the free copper before stopping chelation. So the target in follow-up is to have a free copper between 100 to 150 and a urinary copper between 200 to 500. At the when we start therapy, usually the urine copper in a Wilson's remains 500 to 1000. That is the criteria of diagnosis. Though above 100 is very diagnostic, and above 40, as we have seen in the ASND guideline, is considered as positive. Above 100 is very quite specific. So usually there is 500 to 1000 microgram per 24 hours when we start chelation, and our target will be to between 200 to 500, to bring it to 200 to 500. That means that the chelation is occurring properly. So if it is lower than this, that means the patient is not in compliance, he is not taking drug. So both way, if the patient is not taking drug, urine copper can be very high, or even the urine copper can be low. So there we need the free copper. So if we see that the free copper is between 100 to 150 in maintenance, that means the child has a good compliance, the copper chelation is occurring properly. So we can think of going down on the chelation in those cases and continue on zinc only. So now coming to the interesting part, why I have chosen this case. Uh, so further evaluation of the index case, as we know, family screening and genetic analysis is planned for academic purposes, and whether now to consider autoimmune hepatitis simultaneously in this case. So we had two diagnoses at the upfront because hepatitis B, C was negative. One was Wilson's and one was autoimmune hepatitis. So Wilson's almost proven Wilson's. Now considering the other side of the story, other side of the coin, this child, this is the simplified diagnostic criteria which we follow for autoimmune hepatitis. So either of the autoimmune uh, antibody which can be positive, that is ANA or SMA if it is greater than 1 is to 40, ANA or SMA if it is greater than 1 is to 80. So if it is greater than 1 is to 40, we give a score of 1. If it is 1 is to 80, we give a score 2. And there is another antibody which is LKM. There is SLA. There is the SLA, and then the liver histopathology which we need as a part of diagnosis of autoimmune hepatitis, and absence of viral hepatitis. So in our index case, we see the IgG, which is a parameter that is greater than upper normal limit 1.1 times. If it is 2, if it is just greater than upper, then score of 1. If it is more than 1.1 times, then the score is given as 2. So our child had a IgG almost 2000 at the range of 2000. So it was almost 2 times raised. So he had a score of 2. ACB and HbA1c was negative, hepatitis B, C, so it was score of 2. SLA was positive, so again score of 2. So he had a score of 6. Only thing is we have not done a biopsy, thinking of Wilson's at the upfront. But at any point of time, if he does not improve on chelation, then we have to consider liver biopsy, both to confirm Wilson's by estimating the copper, as well as for seeing to see whether he has simultaneously autoimmune hepatitis also. So coming to papers or literature searching where autoimmune hepatitis and Wilson's can occur simultaneously. So simultaneous presentation of Wilson's and autoimmune hepatitis. There was a case report. There was a case series also where Wilson's and autoimmune liver disease overlap syndrome, a clinical study. This was a case of 10 series. These were pediatric series, so I have quoted these. But there are adult cases also. There are at least six six papers who have actually looked for both Wilson's and autoimmune hepatitis as diagnosis. So in conclusion, the coexistence of Wilson's and autoimmune liver disease is a rare entity, and clinicians should have high level of suspicion in diagnosing the problem. Obviously, there should be a good gastroenterology unit to consider all the investigations to be done properly to make a confirmed diagnosis. Treatment with the steroids and DPNSMN simultaneously may be beneficial, which we will consider in this patient in future if he does not have a good response to only chelation or only the treatment of Wilson's. So coming to the take-home message, Wilson's should be excluded in chronic liver disease in children, and there are strict criteria for making his diagnosis. So Wilson's can be excluded as well as it can be brought in also as per strict criteria of diagnosis. D-penicillamine is the mainstay of treatment. Regular monitoring of illness as well as compliance to therapy is very important. So that's why they need a regular follow-up, because when a child grows into adolescence, usually they start stopping medicines. They go to the college or the hostel and they avoid medicine because they are very because chelation has a very good effect on Wilson's. If proper chelation is done at the early stage, they almost become asymptomatic and they can be continued on zinc even. But however, at any point of time when there is less dietary restriction, exposure to other insults, other offending agents, the child can have again worsening of the liver disease. So that is very important to keep constant follow-up in this patient. Early referral for liver transplantation can be done in case of ALF, that is acute liver failure, or ACLF or advanced cirrhosis in Wilson's or in autoimmune hepatitis. Suspect strongly family history is positive. Simultaneous presence of autoimmune hepatitis is also a known phenomenon. Thank you. So I am ready to answer the questions.
Thank you, Subhomoy. It was an excellent presentation. I'd
Thank
like
you,
to
sir.
ask only one thing. I
Yes,
didn't
sir.
understand about the time frame of chronic liver disease. You
Yes,
don't
sir.
have a time frame now.
Yes, no, sir. Actually, there is no as such definition of chronic liver disease in children which can be available. So I had
Achha.
written a chapter, sir. At that time, I extensively
No, no.
searched.
When do you call it a chronic liver disease? Make it
Uh,
simple so that we can understand.
so as per definition, if there is any feature of chronicity, so in the form of either fibrosis or any sign of decompensation like ascites with a SAG.
Encephalopathy.
Yes, sir. So at any point of time, a child can present with chronic liver disease without a time frame. I will just take 2 seconds more, sir. In autoimmune hepatitis, it has been mentioned that 75% of them can present with cirrhosis at the time of presentation
Acha.
without having a previous history, and
Hmm.
50% in Western, 70% in our country.
Hmm.
They can present at the point of presentation with cirrhosis,
Hmm.
that is chronic liver disease.
Acha. So anybody who is presenting with decompensated liver disease, you can take it
Yes,
as
sir.
a chronic.
Yes, sir. Yes, sir. Yes, sir.
Acha,
Definitely, sir.
acha.
Decomposition
And
is a
and and you said there are more than 90 mutations are there for a molecular
sir,
diagnosis.
sir, 500 now. 500 mutations.
500.
Yes,
So
sir.
when you ask for a molecular diagnosis, 500টাই করো, they do all these 500s.
Yes, sir. Because now what, sir, suppose we are asking for a clinical exome. So where they see, suppose clinical exome for cholestasis. So they see all the exomes of the gene
আচ্ছা
which can
আচ্ছা
cause cholestasis. Now, when we ask for a whole exome, the difference is only 1000, but they will look after all the coding sequence. So if we now ask for a gene mutation, they will see all the mutations, all the possible mutations. Just like pancreatitis, pancreatitis ছটা মিউটেশন ওরা দেখে,
হুম
ছটা কি সাতটা মিউটেশন দেখে। এখন যদি আমি ওকে বলি যে উইলসন্স আমার 500 মিউটেশন লাগবে, দে উইল ডু ইট স্যার, মানে ইফ দ্য দে হ্যাভ দ্যাট ক্যাপাসিটি, আই মিন, টু ডু
ওকে
দ্যাট।
ঠিক আছে থ্যাংক ইউ এগেন
শুভময়দা কয়েকটা কোয়েশ্চেন আছে চ্যাট বক্সে।
So what is the dosage of D-penicillamine? Yeah, very. I actually should have mentioned that. So the dosage of D-penicillamine is 20 mg per kg in 2 divided dose. Okay. So, but in case of suppose if there is neuro Wilson's or neurohepatic Wilson's, then we can start with 5 mg per kg, and every 3-4 days we can observe for developing of neurogenic symptom. So if the child has not developed, we gradually can build up to 20 mg per kg. Similarly, the dose of Trantine is also 20 mg per kg. That is also in 2 divided dose. Only thing is that you should give at least 2 hours of gap between Wilson's, I mean, between D-penicillamine and zinc if you are starting simultaneously. There is no hard and fast rule to start both, but our center used to start both, and the center where I am working now, I start both. That is a standard practice, that you start chelation and zinc both. So give penicillamine 2 hours before food and give zinc 1 hour after food, so that they do not chelate each other. Now, what should be the sibling? When should a sibling of Wilson's be screened genetically? I think there is no as such clinical indication that you should. Oh, you're asking for the sibling? Yeah, sibling should be screened at the time of presentation. So if you diagnose a Wilson, then you should advise the family to get the sibling screen done also, because those siblings can also be silent Wilson. So 3 things you at least do, which are not so costly: get a cave ring done by an ophthalmologist, by a proper slit lamp, get a ceruloplasmin done, and if possible, get a cave ring. I mean, get a urine copper also done. But what you can do is at least a cave ring and a ceruloplasmin, even if urine copper is not possible. So can it be done soon after birth? Birth, actually at birth there will be no manifestation, because you can the birth, if you want to do screening, then you have to do the mutation study, because usually after 3 to 4 years they actually manifest. The youngest patient was below 4 years, I think. So at birth, other than mutation, nothing will help you. So when should the siblings of a Wilson disease be started for metabolic screening? So I think I have explained this question. D-penicillamine challenge schedule. This is a good question, the good practical question. So D-penicillamine challenge schedule is for all age. Remember, for all age, the dose is 250 mg BD for 24 hours. So you give one dose of 250 mg per 250 mg of tablet. It is difficult to do for a very young child who cannot ingest the tablet. But at least if the child is 6 years, you can do it. So one tablet of D-pen 250 milligram at 8 a.m. and you start collecting the urine sample. The next tablet will be at 8 p.m. So from 8 a.m. to next day 8 a.m. you will collect all the urine sample, which will give you the 24 hours urine sample, I mean, for copper estimation. Zinc prophylaxis for sibling. Actually, prophylaxis is not mentioned in any of the guideline or any of the textbook. There is no role for prophylaxis. I mean, it is not practiced. Okay. But if you diagnose them as Wilson, if you can diagnose them as Wilson, then probably you can, as a standard way, if they have features of Wilson's, that is the copper, you can estimate the copper, you can have the Kf ring, then you can start zinc. But I'm not sure about this answer. So modified Calicut score, sorry, I have not gone through this.
Hello,
Yeah.
I'm Bonali here. Any role of hepatic MRI? Does it help in any way?
There is actually very recent paper. I think you have gone through that. That hepatic MRI for copper estimation for diagnosing Wilson. But that is not a standard practice till now in any of the institution. But one thing which I did not mention because our concentration was on liver only. We should do a baseline MRI. I mean, when we diagnose a Wilson who is having a new, at least in an academic institution where MRI is available and cheaper, we could do a baseline MRI to just to see whether copper deposition has also started in the brain. So only utility of this is, one is the academic purpose, and second is once we start chelation in a proper way, we can follow this patient because even the brain copper can be chelated. I mean it can be washed. So to some extent, even neuro Wilsons are also reversible. Some extent it is quite to quite a extent it is available. So when a patient presents with a neuro Wilson with a very devastating character, once you start a proper, after 6 months, we can see a remarkable difference in their neurological worsening. So if we get a baseline MRI done, we can see the copper deposit, and in the follow up we can again do a MRI and see how the copper has already, has started disappearing.
And another thing, quite a few years before when penicillamine was not available, we
Yes.
gave only zinc, and that
Mhm.
also did not, the patients did not deteriorate on that.
But I think all patients did not deteriorated because I think they were already had a good amount of copper chelated before this.
আচ্ছা মানে শুধু জিঙ্ক কি কোনো কাজ করে?
No,
না
no, no, actually you need a chelation first. শুধু zinc কাজ করে পারে when you have already properly chelated, then you can come
when
for
already
zinc.
it was started. Yeah, yeah.
Yes, but I have a different story also. I was in ILBS at that time. So one child who was on in their follow-up was on Wilson, and that time penicillamine was not available. So for 3 to 4 months, the child could not have penicillamine. So he came with a liver failure, with a Wilsonian liver failure, and we started planning for transplant, etc. But however, the time was not given to us. I mean, the child actually succumbed very early. He came I mean, just walking, and he just survived for 7 days, I think, after coming to our OPD. So I still remember the case. The father, we started working on the father for the transplant, but it was not successful. The child actually had a severe sepsis, severe pulmonary liver failure, and ultimately the child succumbed.
Okay, thank you.
Hmm.
Romada, what is the fate for hepatic Wilson patients, those who are not presenting with acute liver failure but with a chronic liver disease?
A very it's a disease, both autoimmune and hepatic Wilson's. If they do not present with hepatic, fulminant failure, then it's a very good disease to treat, because once you start chelation, you will see the improvement of liver enzymes, you will see the improvement in neurogenic symptoms. And but only thing is that we explain to them, we used to explain when I was in PJ, जे खाना नहीं खाना है बट दवाई लेना है, मतलब अगर एक दिन आपका खाना मिस हो गया वो भी ठीक है, बट दवाई लेते रहना है. So that
Now,
they,
is it reversible that once upon a time we can
yes,
stop the chelation and everything?
yes, sir. That is why which I was saying in follow up, if we find that the both the free copper and the urine copper has both come in the range, because it is explained that if the there is a term called over chelation. So if we find that the urine copper is below 100 and if the free copper is below 20, that means we are over chelating. At that time we can stop chelation and continue on zinc only with dietary restriction.
Okay. Okay. Recently, I came across a patient in the OPD. This
Mhm.
is a 15-year-old boy who had been diagnosed as a case of hepatic Wilson's
Mhm.
almost 8 years back in ICH. Then he
Mhm.
was prescribed on penicillamine. He was
Mhm.
diagnosed on, I think, on 2012. He was on penicillamine.
Mhm.
Then he was in very irregular in follow-up, and around I
Okay.
think 2015 or 16, penicillamine was not available.
Mhm.
So penicillamine are not available. They are not given zinc. So he was almost off therapy for last 4 years.
Mhm.
So say he suddenly landed in my OPD just
Mhm.
2 months back with some behavioral abnormality
Mhm.
and some irregular hand movements and
Mhm.
rigidity, difficulty in walking. Firstly, I was not able to diagnose what are the cases. Then I clinically examined. I just found some dystonia like these features. Then the poor father that coming from the interior of the Sundarban, they showed me all the previous papers. Then I found it that he was diagnosed because of hepatic Wilson's, not in failure, but as present as CLD in 2012. He was regular penicillamine therapy up to 2015 or 16 and off therapy for the last 3 months. Now he developed neurological symptoms. So I asked for doing a liver function test. It was normal. They were not very much affording কিছু আইসিএইচ এর বাইরে কিছু চেনে না আসে না সেগুলো আমি করতে দিতে পারিনি. So I talked to the MRI and arranged a concessional at MRI, and MRI revealed features of neurological Wilson.
Very good, very good. So you
Then
got
I
the diagnosis.
then I prescribed penicillamine. The father is telling that it is not available. Then penicillamine is now available. He took penicillamine for last 1 month, and 1 week ago he came to my OPD with almost resolution of the all neurologic symptoms.
That is what I was trying to emphasize, that if proper chelation is done, it is very reversible. Even neuro Wilson's is also reversible.
Well, the father is coming. They are very much poor. And all the symptoms has been resolved just 1 month of penicillamine.
Yes. So
Now what should be the follow-up for this neuro Wilson chelation?
No, he should be continued on penicillamine. He should be continued on penicillamine, and you can add zinc also, and strict compliance to the drug, and you can check the urine copper and KF ring. One thing is very important, that KF ring is present in 95% of neuro Wilsons. In hepatic Wilsons, it is present in 50%, but very likely you will get a KF ring positive also in this case, and you can follow the KF ring also. It's clearly written in all the
KF ring disappears, I think, after
KF ring also disappears of proper chelation. তো যখন ওই তোমার কাছে এসেছিল, at that point you could have done
KF ring ছিল, চোখে খালি চোখে দেখা যাচ্ছিল.
Okay, so fine. So I will take 2 minutes, sir, from Ritopal sir. Just one case I will like to share also from Kushum. There was with Provas. There is a case 1 year back from Bangladesh. I remember the name Shahrukh Khan. He was 8-9 years old. The father is a auto rickshaw puller. So that time also they were unable to procure this D-pen. He actually worsened on D-pen. His neurological features were worsened on D-pen. So the doctor in Bangladesh actually asked him to stop because there was very rapid, he was drooling saliva, he was having extrapyramidal movement. So somehow we convinced the pharma company, Kuchel is the brand name, for Triantine at a very concessional rate. I mean, it is in the market, it is 100 tablets at 21,000. So they agreed to provide at 14,000-15,000 like that. And since his body weight was less, so 250 BD was sufficient for him, which will last for at least 3 months. So after Triantine, there was remarkable improvement, and he did not have neurological features, and he remarkably improved. But then when he came after 3 months, then he was able to manage one more 100 packs. After 6-7 months, যখন আমার কাছে এলো বললো স্যার আর পারছি না. So then we started D-pen again at 10 mg per kg and zinc, and till now he's okay. So after a very aggressive chelation, now we are starting to maintain him on D-pen at a lower dose, so that there is less neurological side effects, and along with zinc also. So let us see. I think he's still now okay. So I have their WhatsApp number. মানে বাংলাদেশে তো WhatsApp থাকে না, অন্য একটা কি হয়, তো ওটাতে মাঝে মাঝে আমাকে ফটো পাঠায় আর কি ছেলের. I will just answer one question. I will take 1 minute because a very esteemed guest has asked me a question, Bikramjit Da. So when should siblings of Wilson's be started for metabolic screening? So at the point of diagnosing a Wilson case, you should screen the siblings also.
Thank you, Subhomoy. Very nice presentation.
Thank you, madam. Thank you.
Good night.
Good night to all.